Good evening, good morning, good afternoon, everyone, depending on which part of the world you are joining. I'm Chandan Mitra. On behalf of Planetary Health Academia, I would like to welcome everyone to our conference today, Family Medicine in South Asia, Challenges and Solutions. I have the honor to moderate the session. May is a very important month for family physicians. May 19th was declared as World Doctors' Day by the World Organization of Family Doctors, known as ONCA, and recognized by the World Health Organization. This year, World Family Doctors' Day celebrated with the theme of Family Doctors Leading the Way to Better Health. The day highlighted the role and contribution of family doctors in the healthcare system towards a better future. ONCA was founded in 1972 with the goals of promoting personal, comprehensive, and continuing care for the individual in the context of family and community, as well as developing supportive academic and research programs for family doctors. Before I introduce our distinguished panelist, I would like to mention few facts about family doctors and overall family medicine. Family doctor is a personal medical guide and health advisor with compassionate and holistic approach to patient management irrespective of age, gender, or organ involved, which is comprehensive approach. Family doctors linking the community to the higher medical centers for specialized healthcare. So it acts as a pivotal role by establishing effective referral of the patients. They keep to reduce the health disparities in the underserved population by strengthening primary medical care at the remotest area of the community. Family doctors are more aware about the specific health needs of the community and changing epidemiological patterns, disease loads, so can be in an important position to public health services. That was in full display during this pandemic. Our distinguished panelists today are from USA, Dr. Anindita Ahmed, MD, MPH. She is currently working as a hospitalist in Resolute Health, Texas, USA. Then from UK, Dr. Abdullah Zakaria. Dr. Zakaria is a GP, principal in Southwest London, a GP trainer and tutor at the George's Medical School, London. He's also a clinical director of East Martin Primary Care Network. From Pakistan, we have two distinguished panelists, Dr. Hina Jawad. She is an assistant professor, family medicine, University Health Sciences, Lahore, Pakistan. We have Dr. Abdul Jalil Khan from Pakistan as well. He's an assistant professor and head of the department, family medicine, Khyber Medical University, Peshawar, Pakistan. From Bangladesh, we have Dr. Lieutenant Colonel retired Muhammad Kabir Ahmed Khan. He is member secretary, Faculty of Family Medicine, BCPS, General Secretary, BSGP. He is also chairman, Platform Family Medicine Wing. From Bhutan, we have Dr. Wangdi Norbu, GP resident, Kaiser Galapo University of Medical Science of Bhutan. From India, we have Dr. Priyatush Kumar. He's chair of ONCA, Rural South Asia, ORSA, advisory board member, TUF executive member, ONCA. We have Dr. R. Gobit from Sri Lanka. He's a family physician, executive council member, Rural ONCA, and he's also co-founder and manager Force. And from Nepal, we have Dr. Amit Agrahari. He's MD, GP, and emergency medicine. He's a family physician in Nepal. Little about me. I'm, as mentioned, Chandan Mitra. I'm from USA. I'm Associate Program Director, Internal Medicine Residency Program in Mercy One Medical Center. I'm also a lead faculty Planetary Health Academia for Internal Medicine. I'm also an adjunct faculty at Harvard Massey Institute. Now I would like to invite our chairperson, Dr. Tasbirul Islam, to kick off the conference. Dr. Islam is our visionary founding chairman of Planetary Health Academia. He is clinical associate professor, Indiana University School of Medicine. He is also medical director for the Department of Pulmonary and Critical Care Medicine, Indiana University Arnett Hospital, Lafayette, Indiana. Dr. Islam.
I think you need to unmute.
Please unmute, Dr. Islam.
Yeah, thank you so much, Dr. Chandan Mitra, for your kind words. Good evening. I want to thank all the panelists for your precious time and joining the webinar today on behalf of Planetary Health Academia. Today, we're going to talk about family medicine in South Asia, challenges and solution. So I'm pretty sure it's a burning topic, and it will be a plus discussion today. And it's very timely, it's needed, surely. What is family medicine? Is a subspecialty which actually provides comprehensive health care for people of all ages. So it's not only limited to acute or chronic medical care services, it also provides services like preventive medical care service, health screening, also provides other subspecialties in a small scale like psychiatry, OBGY, surgery, and so on. So we get confused sometimes with the terms like internal medicine, general practitioner, family medicine, primary care physician. So primary care physician and family medicine is mostly used in North America, and general practitioner is mostly used in United Kingdom, Australia, and New Zealand. So I think it's interchangeable, but internal medicine is quite different. Actually, they actually serve the specific age group, 18 and above, and they only address the medicine. So family medicine, general practitioner, or primary care, they actually address a lot of things. Actually, it's a one-stop service. They provide care to all family members, from kids to old age, all other subspecialties, not just limited to medicine. So I consider family medicine physicians are the main gateway to better health. Not long time ago in US, 1969, the Specialty American Board recognized family medicine as a new specialty. So that is only in 1969. I think in late 50s and 60s, it is recognized in UK and Canada. So I want to give you one picture, which is very scary, but at the same time, it is encouraging. In US, if you go back in 1998, there is almost 3,200 trainee in family medicine, and it dropped to 1,100. So two-thirds drop, actually, almost over 60% drop, the trainee in 2006. So then the US government took the initiative in 2018 called Student Choice Collaboration. And that is actually aimed to recruit the medical student. At least 25% of the graduate medical student take family medicine as their profession by 2030. So it's a good initiative. We're in dire need of family medicine physicians at the moment. So that is one part. So the scope of family medicine, the nature of family medicine training vary considerably worldwide. And the challenges include limited capacity, the incomplete understanding of the roles, variability of the standards and recognitions. So I'm pretty sure today we'll talk about the past, present, and future of family medicine specific to South Asia, and we'll compare with the United Kingdom and USA. And also we'll talk about the challenges, the barrier, the scope, and way to go forward. I'm looking forward for a wonderful discussions today, which is much needed discussion now at the moment. I want to talk about a little bit, maybe a couple of minutes about the Planetary Health Academia, which is a voluntary medical education platform. We started our journey in July 2020 with the aim to exchange views, exchange knowledge, reduce knowledge gap, and train junior physicians in collaboration with local expertise. We have over 150 physicians now as a faculty member all over the world. It's not limited to Bangladeshi physicians. We have many faculty members from Pakistan, India, Sri Lanka, and Nepal. I don't think so we have anybody from Bhutan yet. We have, and we take sessions in Saturday and Sunday, 4 to 6 sessions a week. So we have done over 200 sessions so far. And it's not only limited to medical education, also we discuss burning issues related to health, like today we're doing about the family medicine. So we do sessions as well like this. So I encourage, not only encourage, I request and all the panelists today to help us to grow, to join us as a faculty members, to join us as a participant. Please disseminate the information about our Planetary Health Academia to your country. And we want to work as a team. And we have our website still under construction, but still functional. It's www.planetaryhealthacademia.org. We have our own Facebook page called Planetary Health Academia. So I really want your support, and we are planning, hopefully, in near future, when the COVID is gone, hopefully it will go away soon. In 2023, we'll do some international conference through Planetary Health Academia. So thank you so much, and thank you all for joining today. It's a good evening again, and hand over to Dr. Chandan Mitra. Thank you.
Thank you, Dr. Islam. To set up the stage, I think you nicely summarized what we are planning to discuss. So I think I will go to our first panelist, Dr. Anindita Ahmed for US, to give us a brief overview of the scope of family practice in US. Dr. Ahmed.
Hi, everybody. Thank you so much for inviting me to be a part of this huge international conference. And I'm really thankful to be able to talk a little bit about my specialty. Let me tell you a little bit about the family medicine. It's everybody knows it's family physicians are the one who takes professional responsibility of for the comprehensive care of an individual. Instead of treating the disease, they actually treat the people. So when we talk about the scope of family medicine, it's not defined by diagnoses or procedures. It's actually defined by the human needs. They are the expert at managing common medical conditions, recognizing important diseases, also managing acute and chronic medical issues, diagnosing hidden conditions. So, and as a family medicine, you not only treat a single individual, but you treat the entire family, from the infant to all elderly in the same family, and that's the scope of the family medicine. And if a family physician has a particular interest in one of the specialties, say for example OBGYN or sports medicine or sleep medicine, they can actually do specialty training, and that broaden their scope of practice. So when we talk about family medicine, it's huge, and like Dr. Islam said, that it's becoming more popular in US, and then US still has deficit. The data showed that the deficit of 52,000 of family medicine by the year of 2025. So we are working on more medical graduates. At least like 25% of the medical graduates would need to go into this specialty to make up all those deficits. So there is a lot of scopes in the family medicine. It's very well recognized now here in the Western countries, and people are more being dependent on this specialty.
Thank you, Dr. Ahmed. So now I will go to Dr. Abdullah Zakaria to give us a brief overview of family medicine in UK. And as we know that family medicine is known in different ways in different countries. Like in UK, I think that part of the world known as a GP. So I would request you to shed some lights on family medicine in UK. Dr. Zakaria.
Thank you, Dr. Mitra. Thank you very much for inviting me. 2 to 3 minutes is actually only, I can just say the headlines, maybe. Perhaps I can just start by saying that general practitioner or GPs, the way that we know back home and the way that we know in this country is completely different. So basically, GPs are in the driving seat to operate the total healthcare system. So if I just not going into how GPs, they do their healthcare, if I can just say that apart from managing patients, GPs are in the driving seat to shape the health and care system by commissioning services, by digital transformation, by building integrated care system, workforce development, enhancing community and public health and social care. So it's actually all are interrelated to each other. I'm just telling you all these headlines. The situation at the moment in the UK is like we have 35,000 full-time equivalent general practitioner in the UK, well, in England. By the way, UK is a combination of 4 countries, England, Wales, Northern Ireland, and Scotland. And if you look at the population, UK has 66 million population. 56 million of them live in England. And I'm talking about England because I live in London, and the health is a devolved matter, like the way that it is operated in perhaps in USA. You have a state or like a federal government, and we have this thing called in 4 countries, and they have a slightly different health systems. So the data that I'm sharing is actually related to England, or English health system, shall we say. So annual graduated people coming out of the system would be 3,500 medical graduates. They come to general practice, and it is the highly sought after specialty now, not only because it's highly paid compared to other specialty, but also it's actually giving you a lot of opportunity to develop your special interest. Like myself, I work part-time in rheumatology, and I'm a part-time GP. So it can be quite confusing because in my credential, it says GP and a rheumatology. So it's slightly confusing. So I do part-time both of them. So you can also develop your special interest in lots of other areas, like an educationist, training, teaching. You can do other things like you can develop your specialty in a special interest area and run clinics in the hospital. As a leadership role, this is something new through the General Practice Bill. The government is actually brought about to give the commissioning responsibility to general practitioners. The way that the certain area of, let's say I live in London, so London has different strategic areas. Southeast London has 5 borough, what we call is like a council or area, which has 1.5 million population. So we actually plan the healthcare service for this population. I'll talk about this a little bit more later, maybe, but I'll stop here. Maybe I'll come back to talk about the digital transformation and so on.
Thank you, Dr. Zakaria. So from Dr. Ahmed and Dr. Zakaria gave us a nice overview of the Western world and the scope of practice. But from the data, one thing is pretty evident that we still need a lot of family medicine doctors in US and UK, and government is working towards that path. So now I will go to our next panelist, Dr. Kobir Ahmed Khan. Dr. Khan, if you can give us an overview of how the scope of practice of family physicians in Bangladesh and give us some statistics that how many family medicine trained physicians are there and what is the optimum situation looks like. Dr. Kabir Ahmed Khan. Dr. Khan?
It's frozen for some reason.
Oh, okay. So I think I will come back. Okay. So maybe I will come back to Dr. Maybe I will come back to Dr. Kabir Ahmed Khan a little later. So let's look at in our neighboring countries there, in Pakistan. We have two distinguished panelists.
I was disturbed by the net.
Oh, sorry.
Oh, no, sorry. Extremely sorry. Extremely sorry. Actually, I would like to convey my gratitude to the Planetary Health Academia for arranging such a useful and required subject for discussion today. And I am congratulating everybody for participation today. And I think you all will give your inputs, and so that we can get some way forwards to establish our family medicine and family doctors in our country, in respective country. Now, actually, family doctors, family medicine, and the World Family Doctors Day, all three words has been explained by the Dr. Tasbirul and as well as our moderators today. So we are not going to those things, but family doctors concept has evaluated from the ancient GP or general practice, and from there the old GP has reinvented or reborn as the modern GP, that is the family doctors. So, and for modern GP, here the we know the after World War II, the things has been healthcare has been fragmented rapidly for specialty in various specialty and subspecialty, and the old GPs, those who are the practicing the GP and in the grassroots level, they started to thinking that they have to earn some more knowledge on medical education and the medical technology, and subsequently all the research activities established that a new subject has to be created to teach these new GPs, so that they can tackle the primary care illness almost 80 to 85% at their doorsteps. And ultimately, the family medicine has created, and this has been created declared as the independent subject specialty in USA in 1969. We already heard it, and subsequently in 1972, World Organization of Family Doctors is established as commonly known as the ONCA. And after establishment of the ONCA, worldwide, this family doctors concept has been spreading very rapidly. And WHO, when declared in 1978, the World Health for All through primary health care, and that was the philosophical foundations for the family medicine or the family doctors and the primary care. And ultimately, all over the world, we heard that in the developed countries it is established now, and it through the family medicine doctors, the family doctors, they established the healthcare delivery system and the strong primary care. Through strong primary care, they are giving their healthcare delivery system. But in developing countries, especially in South Asia, including Bangladesh, we are lagging behind, far behind. Though our country, our population is facing much more illnesses, especially the communicable diseases and the non-communicable disease also increasing subsequently as the life expectancy also increases in our South Asian regions. But though we are facing, our people are facing much more diseases in the primary level, we are lacking behind the primary care physicians or the primary care team members. Bangladesh is not exception of that situation. If I can tell regarding a few words regarding the Bangladesh health system. Everywhere the health system is structured at the primary care, secondary care, and tertiary care. In Bangladesh also, the primary care infrastructure is there. Suppose the community health clinic at the village level, union level, the health centers are there, and Upazila level there, the Upazila health complexes are there. These three components comprises the primary healthcare delivery system in our country. But unfortunately, this component, primary care delivery system, is not properly working because of as there is no effective referral system, or there is no the policy formulation or the government implementation of the rules that from basic level, that is the community health level, the patient should come up to secondary tertiary care through the referral sheets. But people are not habituated with that. People can go from primary level up to the tertiary level without any referral sheet or without any, but they can choose any places to go for their healthcare delivery. So in our country, the primary care is not that much strengthened, organized through government or in the private level also, because you see that in one study they proved that they show that.
Thank you, Dr. Ahmed. I think you are bringing up some nice segue for our next few questions. You brought up some challenges while you are describing the present situation in Bangladesh, like the primary, secondary, and tertiary level of care, and there is not much coordination between that system. And I think maybe we can discuss a little bit more in the future in that regard. Maybe I will go to our next panelist at this point. So I would like to welcome Dr. Hina Jawad. She is from Pakistan. I would like to know from her the present situation in Pakistan and some of the challenges, like Dr. Ahmed was, Dr. Kabir Ahmed Khan was mentioning, that discoordination between the primary health care and the specialty services. Dr. Hina.
Thank you very much for the opportunity. I think I'll just go straight to the point. I think looking at the grassroots levels, if we start from the undergraduate, there was a study carried out in Lahore in 5 medical colleges to check the understanding and to assess whether the final year medical students knew about family medicine. Only 38% knew about it. The figures are appalling. I wrote that as part of my print media. I write in newspapers as well, and this article was written in collaboration with Dr. Jalil Khan, who's the next speaker. So yeah, that was quite shocking. That was one of the comments that came back from various people, that only 38% knew. And I think the regulatory bodies, the Pakistan Medical Commission, previously called Pakistan Medical and Dental Council, they issued a notification in 2014 stating that family medicine has to be a mandatory part of medical colleges. So you need to have established a department and have a faculty. Unfortunately, that has not been acted upon. So as a result, we do not have any recognition in the undergraduate level. We haven't got a curriculum of family medicine incorporated into the undergraduate level. Now, moving on to the postgraduate, we haven't got many programs to offer. And I'm talking about the major areas of Pakistan. I'm talking about the provincial, because after the 18th Amendment, the legislation, health is a provincial matter, like one of the doctors earlier said about the UK. So Punjab, KP, Balochistan, Azad Jammu Kashmir, Gilgit-Baltistan, these are the, including the federal capital, we haven't got many postgraduate qualifications to offer. As a result, we are not able to produce faculty. As a result, the number of trained, qualified general practitioners are lacking in the country. So these are some of the really crucial challenges that we are talking about. And I think we've managed to get the spotlight to family medicine that is very much needed through lots of avenues, multi-pronged approach, particularly in the last year when we were heavily involved in telemedicine, we were able to bring the spotlight. And I think having this session is an example that family medicine is now the buzzword and is being talked about a lot. So I think that is hopefully the way forward and the future. Thank you.
Thank you, Dr. Hina Jawad, I think that is kind of shocking to hear, but I'm sure none of the panelists are surprised to hear that number, that only 38% of the graduates know that this is a subspecialty. So I think we need to create more and more awareness about family medicine, and we need to talk about, I think one way to do is to talk about what are the services, what are the values of family medicine that we can provide. So that would be my next question for our next panelist, Dr. Abdul Jalil Khan, who is also from Pakistan. And I would like to ask him in what Dr. Hina Jawad was mentioning, how we can create some of the awareness to face some of the challenges that is going on among the trainees. Dr. Khan.
I think he was having internet issues earlier. We'll just give him a few minutes to connect.
Thanks, Chandan. I hope you can hear me. Sorry, my connection got a bit jittery.
Yes, we can hear you.
Can you hear me? Oh, thank you. Would you mind just repeating? I thought you said, how can we increase the awareness? You said.
Yes.
Yes.
Okay. Yeah, thank you very much. Yeah, it's a very important question. And as Hina rightly mentioned, that there's a big gap and we need to ensure people are aware of this. So in Pakistan, the history of family medicine starts in 1992. We had even fellows, but unfortunately, the specialty didn't establish as it was supposed to be. And one of the reasons was lack of awareness plus lack of primary care, family physician post in primary care. But having said that, now that people are getting more sensitized to family medicine, and I would say the credit does go a bit to WHO as from 63rd session of the WHO Eastern Mediterranean region, in which all member countries, I think 22 countries in October 2016 participated in it. I think Dr. Kabir Khan mentioned a bit about that as well. And since then we realized that Pakistan will need more than 70,000 family physicians if we want to achieve the target of 3 GPs per 10,000 population. Myself and him have been trained in UK. We are trying to get around 15 to 1,700 per G. You have to create 70,000 GPs. So it's a huge number, and it's not easy to do that in the next few years. So that's why they adopted the approach of bridging programs. We started 1 year short course programs, and that did increase the awareness. People are more aware about it now. We tried to fight on the front of undergraduate curriculum and get family medicine included in undergraduate curriculum, so people get more sensitized and choose this as a specialty. So now we are hopeful. A lot of medical institutes are now recruiting faculty for family medicine, and they're including or rather talking to include 100 hours in undergraduate, and they realize and they know that this is not possible without adopting the family practice approach. So these are the areas which we can see opportunities for us. Yes, there are a lot of kind of a new discipline. You create opportunities. That's how I could see. So any specialty like public health, if we talk about, they create faculty posts, they create Pakistan family, that will encourage thinking about UK model to not just put doctors in public health family medicine clinics, but also to contract out in public-private partnership the essential health service package. So that will not improve the trust on the primary care, but that will also encourage trainees to open their own practices and then get the contract from the government as part of the essential health service package and get paid through the government. I think that's a UK same model, like NHS pays to private GPs, NHS pays to public sector GPs as well as per patient population. So that's how I could see, and I think, as I said, bringing it at undergraduate level will definitely encourage. So it will increase the awareness and it will encourage people to come here. Plus one, I will finish it here. In EMEA region, few countries are even thinking not to allow those students who have just completed MBBS, like completed the medical school, to be able to go into general practice directly. Rather, ask them to do a short course, at least in family medicine, if not possible, the full fellowship, at least like a 1 year or 6 months program. And that will also encourage people to take family medicine as a specialty. Thank you.
Thank you, Dr. Khan. I think you mentioned some very important points, like I think all of us are struggling with the concept how to train and attract the next generation family care physician. So I think that concept, I think we can come back again that you mentioned that, okay, it might be really hard to attract the new trainees within fresh graduates, what is in there for them. But the bridging program is a great idea, I think, that, okay, right after graduation, that if someone doesn't want to commit of 3 years of postgraduate training, then 1 year of short course, can they give them a head start or at least a path forward to that way. And I think another important point you mentioned, like private government partnership, which is the UK model. We can come back to that concept again. I think we are getting some very important point across at this point to different countries. I will hold on those thoughts and come back again. Now, I would like to go to Dr. Pratush Kumar. He is from India. And my question to him would be, how is the structure of primary care and the level of the secondary and the tertiary care health system, and what is the role that family physicians are playing in there? Dr. Kumar.
Thank you everyone for inviting me to this platform. And this is a very important discussion which is going on regarding family medicine in South Asia. Overall, what we are seeing, the family medicine is in infancy stage when we compare to other specialities which have been there for so many years and well developed, well recognized. And some of those challenges are because of our other departments, because they're well established, and our department is just started up and it's getting recognized, but not yet accepted overall. And we don't have much more training programs. They are not more interested students willing to do their career in family medicine. So these are some of the basic challenges which is keeping it us away from the progress and growth of family medicine in India. But going back to the concept of primary healthcare in India, it's something like by the concept, by the design, it's something very comprehensive. Like first we have got a sub-center which caters to a population of around 30,000. Then on top of that, there's primary health centers which caters to much more population up till a lack of population serves. Then we have our PSC, we have got community health centers and district hospitals. And on top of that, we have got medical colleges. And on the Apex, we have got Apex institutes like AIIMS, All India Institute of Medical Sciences, which caters to much more specialized population. But the role of family medicines, if you'll ask me specifically what's the role is not well defined, because you'll find family medicine, the family doctors serving at each levels, at the Apex Institute also, at the rural, at the grassroots level also. Because family medicine by a concept is a point of first contact, whether it be any place, because the concept of referral services, like here in India, anyone can go directly to a medical college. They can directly visit any primary health center, CSC, or medical college as the point of first contact by default. So we need a family doctors at each step, and they could be based on the concept that they need to resolve more and refer less. And if we get first a referral mechanism in place, then obviously we'll get much more strategically placed role of family doctors, where they could be much more serving in the primary health centers or CSC, where they could provide the more comprehensive kind of care, including the treatment part also, but also rehabilitative, preventive, and promotive part also. So this is something in brief, what's the structure of family primary health care in India and the role of family doctors. Thank you.
Thank you, Dr. Kumar. I think there is another point that came up from your discussion, which is the referral system. But thank you for describing the structure of the healthcare system in India and the role of the primary care provider in there. But you also emphasize that how the primary care physician or family physician or general practitioners, as across the pond, we are using different terms, but it all means the same, how they can provide the comprehensive health care to the population, and it can be one-stop shop type of thing. So no, thank you for pointing out those important points. I will go to our next distinguished panelist, Dr. Gobit Ratnam from Sri Lanka. So I would like to ask him, as Dr. Kumar was mentioning the structure of the healthcare system in India, how it is different or is it similar in Sri Lanka, and the role of family physicians in the healthcare system overall in Sri Lanka. Dr. Ratnam.
Yeah, good evening, everyone. Just like Prithu said, the Sri Lanka also same like kind of Indian system. You all know the small island country of Sri Lanka having the family doctor system for the over century, though we don't have much recognized as a curriculum of family medicine or specialty of family medicine. So we had our own professional bodies since 1929 and our own College of general practitioner in 1974. Recently, we have former Sri Lanka Association of Family Physicians as well. From 1979, the family medicine recognized as a specialty in curriculum level in the postgraduate level. And we have undergraduate curriculum from 4th year onwards in all the medical faculties since 80s. Now almost all the faculties have the good curriculum system in the undergraduate. Also, from the postgraduate level, we have the diplomates and membership exam college, as well the MD Family Medicine. Then MD Family Medicine we started in by clinical in 2000, and recently now only we are producing little number of around 30 specialist family physician and over 2,000 diplomates. So especially that specialists are placed on the district hospital in the limited number, though there's a 347 district hospital, but GPs are the part-time base in the after hours. But as Pratyush said like that, any patient or want to choose the place to go even for the secondary care or tertiary care without the proper referral system. The role of family physicians as well same, we always go with the principle of family medicine. So they do all the patient-centered and complementary and continuity care. That wise about the family medicine scope. Actually, we are the growing field, the demanding field among the post-intern doctors. And recently, in 2017, we started the strengthening of primary care project. It has got the more important, and we are putting the family medicine and producing more family physicians. Currently, we are only 5 per intake per year, but anyway, from last year, we are at 15. We are planning to at least 150 per in 2030. So I think we have the scope of going for as a primary care system with the family physician involvement. I think this is enough up to now. We will discuss further a little bit later after that. Thank you.
Thank you, Dr. Ratnam. I think one of the challenge, I think everyone is mentioning the challenge of establishing a proper referral care system. And it is nice to know that at least government now have a plan from 2017, how they can revamp the primary health care. Actually, that is the skeleton of the healthcare system or backbone of the healthcare system. You also mentioned one thing that the curriculum, how to develop the proper curriculum, right? I think that is really important. That's if we can develop a proper curriculum to train the physician, I think they will be better equipped or competent to take care of the diverse need across all ages and sex and organ systems that family medicine can handle. We can create more competent physicians in that way. I think I will go to our next distinguished panelist, Dr. Amit Agrahari. He's from Nepal. And in short, if you tell us if there is any difference in primary healthcare structure or the referral system. But my main question would be to you about the curriculum to train the primary care physician or family physician, and what are the challenges in Nepal to do that? Dr. Agrahari.
Good evening, everyone. Thank you for inviting me for putting some points. The structure of primary healthcare in Nepal is similar to the neighboring countries like India and Pakistan. We have primary, secondary, and tertiary level of hospitals in our country, and at every level, GPs have been prescribed some role. They have some important role playing played at every level. The GPs are usually placed at the level of district hospital in most of the district hospitals, and there they have to play the role as a doctor, that is a clinician, as well as an administrator. They have to look after the every aspect of the hospital, as if they are the whole the fund that comes to the hospital. They have to manage everywhere how it can be utilized, and as well as they have to look after the clinical part of the hospital, to look after the staffs, where how to manage them, where to utilize them, and in usually, and we have been working as a first contact physician at the level of villages. In the small villages, we have been working as a first contact physician, and at level of tertiary care, that is at the zonal hospitals as well as medical colleges, we have been given usually the role of emergency physician. We are usually given the role of emergency physician. In very few medical colleges, we have been given role as general practitioner or first contact physician. And there are laws in our country that Nepal Medical Council has told that every medical colleges should have a department of general practice and emergency medicine. But most of the medical colleges do not have the department. They just want they want the family physician or GPs to look after the emergency, not the general department of general practice. They really don't allow family physicians to flourish in their usually it is usually in the private medical colleges. And hello, Chandan. Yes,
we are hearing.
Yes.
We can hear you.
You asked something else. I thought.
No, I think you brought up some good points. We know that doctors wear many hats, and how a primary care physician is responsible to provide the first contact of the healthcare system, then in the primary care, then as well as in the emergency room, as well as they have to manage the administrative capability as well. So that's a huge task to undertake.
Yes, that is the main problem, that we have very few. We have about 350 general practitioners working in Nepal now, and we have many district hospitals in the hilly areas. They have the family physician. They are equipped with family physician, so they look after most of the cases there, and that has caused less referral from those remote areas to the towns and cities. That has decreased the financial burden to the patient as well as the government, and that is an important role. We have been playing important role in the care of the patients usually at the remote areas of Nepal.
No, I think that's the main goal of the primary care provider, right? I think primary care providers are family physicians in Nepal doing a phenomenal job, but the number of family physicians that you mentioned, I think that's not mere enough. Let's put it that way.
That's not enough, but we have, but it is increasing as we have now. We produce about 60 to 70 family physicians per year. So we'll have the number will at least double in next 5 to 7 years. We are hoping for that.
No, I think it's nice to see a nice path forward. Maintaining the theme, I think I will go to our next panelist, Dr. Wangdi Norbu from Bhutan. And I want to ask him that as Dr. Agrahari mentioned, in Nepal, the challenges that primary care provider is empowered to do so many jobs at one point in time, but at the same time, how excellent service they're providing, quality of care, reducing the referral. Is family practice or job description of a family physician is similar in Bhutan, or is there any differences, or do you have more hats to wear in your country as a family physician, or what are the other responsibilities that if someone didn't mention it yet?
Thank you, Dr. Chandan, for your warm welcome and great introduction. Very warm greeting from Himalayan Kingdom of Bhutan. Respected distinguished, it's my pleasure to speak in this forum and take you to the GP program or family medicine program in Bhutan. To say Bhutan is a very small country with just a population over 0.7 million, it's 0.7 million, and we just got 2 GP specialists who graduated from India and who is currently mentoring us as GP resident. So GP program in Bhutan was established in 2017, and we are happy that we are having our own graduate from only one medical university, that is Gesal Kerpo University of Medical Science of Bhutan. So she will be graduating this year. So she will be the 3rd GP specialist getting into the pool. And to say that we have only 4 GP resident till date. And so each year we'll be producing only 1 GP. And this year there were no one who took up the GP program. So I would say like the challenges in the GP program in our Bhutan or the family medicine program is the lack of identity, recognition, as most of the panelists mentioned, because now GP program, even there is no definite or like recognition or identification by our colleagues also, even our specialists, other specialities, they also doesn't know much about the GP program. And as you asked me a question, since we have got only 2 GP specialists in our country, and we have to wear different hats. We have to work as a clinician, we have to work as an administrator. So our 2 current GP specialists who are in National Referral Hospital, they run a general OPD, seeing around 70 to 80 patients a day. And they also look after some administrative work, and they also mentor us. They work as a faculty member and they mentor us. So they are overworked, I mean, as a GP specialist. And I hope GP program in Bhutan, I must say it is at an infancy stage, and hope that GP program will enhance, and let's pray that GP program will flourish in the near future to come. Thank you, sir.
Thank you, Dr. Norbu. I think it's nice to start somewhere, and at least started, as you say, you're at the infant stage, but definitely I think hopefully from today's conference we can get some ideas and how to help each other and collaborate and create. So,
now whether you can see,
did you raise your hand? You wanna supplement?
Yes. Can I just ask, out of interest, a question to Dr. Norbu? You mentioned there are 2 GP specialists trained in India.
Yes.
They came to serve in Bhutan. So
yes.
What type of postgraduate qualifications that they do in India? I mean, what is this program there in India? Or maybe my Indian colleagues may help with that.
Yeah, I can help.
The dog is barking. I think you got to give something to your dog.
So in India, we have got two types of qualification which is recognized. One is MD, MD Family Medicine, and the another one is called as DNB, which means Diplomate of National Board. Both are well recognized by Medical Council of India. But apart from MD and DNB, we also have got some different courses for family medicines. Like there's this CMC Vellore is there, Christian Medical College Vellore is there. That runs its own course that's called as Distance Learning Program in Family Medicine. And there's another program which is called MMed, that's also in family medicine. So there are two different programs by CMC Vellore, which is even sponsored by many state governments for its own MBBS doctors to do some more kind of training. It's something like a training for their own doctors. Okay. So CMC Vellore program is very well recognized among doctors, but it's not recognized by the MCI, Medical Council of India, which is now the NMC, National Medical Council. Okay. And apart from these two courses by CMC, we also have got MRCGP programs, which is done by the Royal College of General Practitioners. These programs are there. Then there's another fellowship programs are also there, which is run by some universities. Even our academy also started running this course. Then there's something called as FCGP, which is done by the Indian Medical Association. They also have the General Practitioners Network. They do then their own FCGP programs. So there are different fellowship kind of programs are there, but overall only two programs are recognized by the National Medical Council. That's DNB, Diplomate of National Board, and the MD. And the annual number of seats, if you'll ask me, is something around 150 total pass outs every year we can expect. This is the status from me.
So do you need the qualifications to practice as a GP? Is it a mandatory qualifications that before you can start your practice? Is there something stipulated somewhere in the regulation?
No.
In India?
No.
No. Okay.
MBBS is enough to do.
That's all I wanted to ask. Brilliant. Thank you.
No, thanks for clarifying, Dr. Zakaria and Dr. Pratush Kumar. So I think, yes, that could be a great challenge, right? Like we are talking about that anybody can pass from graduate from their medical school with an MBBS degree and they can practice as a general practitioner. On the other hand, we are talking about doing additional trainings. As Dr. Kumar mentioned that there are several trainings out there and two of them are recognized. One is MD. And so I think it's always a dilemma, right? That why I have to do or go through additional years of training to do the same scope of practice. I think most important thing is there that we need to create the value, or we need to create a brand that, okay, people will know what are the additional services or what are the that they can provide. So it's better to go to a well-trained physician, not like just graduate from the medical school. I think that's where the concept needs to come from, right? Creating that value. And I picked up one thing from Dr. Nurbu when he was talking about the reason they didn't fill out the spot that goes along that theme, lack of identity of that family medicine provider. I would go to our panelist from US, Dr. Anindita Ahmed, and I would like to ask her that as a family medicine trained resident and as a primary care provider, how they are recognized and what are the value that they provide in US, that because she also already mentioned, and I think Dr. Islam mentioned as well, that what is the plan going forward, how government is creating some incentives, opening up some more primary care residency, and more graduates are entering into this pool. So what US did differently, and how is there any lack of identity among the family care provider in US?
I don't think so. I think, like we said before, me and Dr. Islam said before, that we are still short of family medicine, and to create the awareness about the specialty, what ES is doing, they're incorporating in the medical curriculum, they're incorporating more rural, rotations. So what they do, they're exposing students to the rural areas, and then they're exposing them to the opportunities, and they are actually kind of like trying to show them what are the positive sides of practicing. If you can, the thing is, like, the family medicine, they're more needed, much more needed in the remote areas than in the urban areas, because urban areas, there will be, most of the people would want to live in the bigger cities with more, other opportunities, like school wise, and then, other recreational activity wise. But the positive side of the US is, it's not not everything is centralized, like centralized to one or more cities like we have back in home. Everything is centralized to the bigger cities. Here they're spreading out all the opportunities in the rural areas. So what US is doing, they're trying to encourage the students to go do more rural rotation. That's a part of their curriculum, and they're trying to show them what are the benefits, and then what are that they can have like a good lifestyle. They can have like a, no, they don't have to deal with the traffic. Incentive wise, it's actually better than living in the city, the cost of the living. And sometimes it helps if that medical student is from the rural areas, and they tend to go work more to that setting. And then also the quality of the life, personal life, is much better. So those are the positive sides of the rotation, the way it works. Those are the positive sides they want to focus, so that they can attract more medical students to go to the specialty.
No, thank you, Dr. Ahmed. I think this is something that we always think that we really need to create our value, right? So that people can recognize, and then they come to that specialty. So sometimes we think about, let's say, pulmonary or cardiology. I think they are very well defined, that, okay, why I have to go to that physician, right? So that's why sometimes in Southeast Asia, people go to a specialist bypassing the primary care health provider. But I think the value that we are talking about, we can touch on more concepts, that what are the value that we can add to that profession, so that people can understand and choose the primary care physician as a one-stop shop, so that their diseases can be managed earlier and establish a good relationship. And I think Dr. Ahmed was talking about some of the incentives. I think, yes, if there is a specialty or subspecialty lagging behind, but there is an increased need from private or government sector, we need to create some incentives for them and make it very attractive. I know that in US, there is one incentive out there. I think everybody knows there is a, when you finish your medical school, and by the time there is a big loan behind your head. So I think actually the government created some program like loan forgiveness program, that or they will give you extra incentive to go to the remote area or practice there. But at the end of the day, I think in Southeast Asia, what it matters most, that how people know. So I would go to our next panelist, Dr. Zakaria, and I want to ask him that access to the healthcare that we are talking about. So how you see the challenges, the barriers in between the developing and the developed countries?
Thank you, Dr. Mitra. I couldn't really stop myself not commenting on this couple of things that just we discussed. I mean, it's so much dear to my heart, really. it's not only just you incentivizing people to come to general practice, as you are absolutely right that we need to create the value. But how do you do that? You know, if you don't have a recognized postgraduate qualifications, you can't really do that. And the other than that is the market economy is such, if you are really providing a good quality care, people will come to you. So that's the truth. So let's be honest, let's not beating around the bush. It's actually the creating the value, meaning that you have to have a high quality of general practice, okay? Let's not try and say that, look, you know, you come out of general, you know, your medical school and you open your shop and you provide general practice. In the UK, you will have to do 2 years foundation degree and then 3 years of vocational training to become a GP, which is going to be 5 years training. So in total, 7 years and 5 years of medical school. So total 12 years of your training to become a GP. So in order to become that level, so it's a quality issue, I see it. And the other one is I'm going to leave that blame to this government's place, because they should recognize that people shouldn't be queuing up the tertiary hospital to get their OPD service or primary care. They should be going to general practice. In the cities, you can see that. I'm also going to blame the academia and the doctors' trade union, BMA and others, who should be really voicing these issues. We are, you know, in a couple of hours, we have spoken to so many things, can't really go into much detail. But what you've asked me about the access issue, in the UK, the access is slightly different. The issue that we are facing is slightly different than back home, right? So here's the issue is like we are now most used to with the service like 24/7, Uber Eats, Amazon, same-day delivery, and we want my GP on the app, and I want to talk to my GP or family practitioner right now. So that's the demand of the population, right? So we haven't been able to increase our general practitioners because UK is in a very unique position. Once they graduate from this country, they all go to, you know, there are 6, 7 English-speaking countries they can go and work, except US. They can go to Canada, Australia, New Zealand, and other places and can work. So we actually compete with those countries. And the trouble is, in order to, you know, produce the general practitioners, we will have to put them through to this training program, and training program has limited number of positions. So we can't really, you know, allow people willy-nilly go to general practice training program. So that's one barrier. The second barrier is once you qualify, a lot of people, they don't want to work in the rural areas. So let's say, for example, if I post you to Scotland Hebrides or somewhere in Irish or some other island, you don't want to go. Everybody wants to work in near the city. So that's the problem in the UK, I suppose, as opposed to USA, which Anindita might be, you know, saying that people should be incentivized to go to the outback. In Australia, they call it. Yeah, we call it rural or countryside, shall we say. Right, so that's second problem. The third problem with the access is nowadays, because we can't really increase our workforce very quickly. We cannot really increase the investment, i.e. the financial funding program through the National Health Service. The whole service is nationalized, by the way, and I should really brag a little bit. NHS is not the top class health service in the world, but it is the most cost-effective one, i.e. the pound or dollar that you spend, you get the best out of it. So that means that the GDP spending that we are doing, 9.5% of UK GDP, the outcome measures is pretty good, but it's not the top of the world. I must emphasize this. So what I mean by saying that is because of the general practice as a bedrock, or if you like, a gatekeeper to all the services, they actually monitor the service very well, i.e. they monitor, you know, how many people are going into the specialist care. They also monitor the outcome of the hospital stay or even the ED attendance. So a patient coming back to ED, and I look at the discharge summary, and actually, if it is not up to the scratch, these general practitioners are being trusted to report it, that this hospital is not performing. So you see, they by default become a regulator to the hospital services. So I'm not going to say just that incentivizing is the only mechanism where you can attract new brain or new talent. It's also to give the job satisfaction they are doing. So the other point I was going to say, the access issue is now somehow mitigated by triaging system. During the pandemic, what we have actually done is in every level, like if a patient is calling you, telephone or online or apps or face-to-face, all patients get triaged by the non-medical people, like non-GP, in other words. So the non-GP people are like a navigator. They are called care navigator, which means that they take the history and decide what is the best route for that person to go. Let's say, for example, somebody is calling you, they want a travel advice. So the care navigator will book with the nurse instead of a GP, because GP doesn't do travel clinic in the UK. It's really run by the nurses. So that's how it's happening. And there is a bunch of other professionals, allied healthcare professionals, they are coming to play now. Government is funding now advanced nurse practitioner, clinical pharmacists are working with GPs, so medication review goes to them. The physician associate, which is an imported idea from America, which is a full-fledged program now going on in the UK. There's something called paramedics are working with the primary care physician. They go and do the home visits nowadays. In my practice, I've got a couple of them. The health and well-being coach or care coordinator, these are the different breeds. What they do is they usually go after these long-term condition management. Say, for example, somebody has got a chronic disease of heart failure or Parkinson's or something like that, so they will organize their care coordination. So lots of other work is happening. So I was going to say, it's not the number of doctors that you have in a country is the indicator, but also the other allied healthcare professionals that you need to provide a quality of care. It's not only just producing doctors, but also the other things. You're starting from your ambulance to hospital beds to specialists to other areas. So these are more important. Now going back to our countries.
Dr. Zakaria, I think you brought up some very good points to the conversation here. So I definitely agree with the teamwork that you mentioned, that it's not only the physician that we can do all, but also how we can provide the quality care and how the job satisfactions of the physicians matter. But thank you for bringing up those points. Those are really important to survive as a physician and be happy at your work. I will go to Dr. Hina Jawad at this point to ask her regarding that training, physician training and allied healthcare professionals, but my specific questions to you would be about the postgraduate training, the structure, and how to bridge the gap in respect to accountability, clinical governance, research, reflective practice, leadership skills, and if you want to supplement anything with Dr. Zakaria just mentioned.
Thank you, that's fine. When we say, I was trained in the UK and we were trained to be patient advocates. Now, when you have to do patient advocacy, you have to acquire the leadership role. And in order to do that, you have to go through a structured training pathway, which includes a lot of reflection on your clinical practice, just thinking about how you acted, why you did that action, learning from mistakes. As part of our annual appraisal, we have to do a certain number of CPD points. We have to state any compliments and complaints. There was one year where I had 0 complaints and my appraiser said, that's no good. We need to know about any complaints, no matter how trivial they are. So I think that tells them and us the type of person we are and what role we are acquiring and our own weaknesses and strengths. And the workplace-based assessments like case-based discussions, again, reflective practice, COTS, the mini clinical evaluation. We actually tried to do that in one of our diploma programs in Lahore when we did. And amazing reflections and stories came out of the postgrads. They recalled some of the events that took place earlier on in their career, particularly those that were quite advanced in their careers, and they joined the diploma program. And it just seemed like nobody had ever asked them the question about it. They were never given that opportunity to express how they felt about a clinical event. So I think it's just providing an opportunity. At times, I feel like whatever I have learned in the NHS system, I'm trying to practically utilize it in the Pakistani system. I'm thankful to the university for giving me an opportunity to be able to do that. And I think that is something, because I know the importance of training. And that's what I advocate for at every level, starting from our provincial ministry to the bureaucracy, to the health secretary, and so on and so forth. So yeah, that's what I wanted to say. Thank you.
No, thank you, Dr. Jawad. I think reflection is the first step to move forward. We need to learn from the past, but the irony is we don't sometimes learn from the past. We want to, I just want to mention that, we have Facebook Live going on. We have the chat box open. If anyone has any specific questions at any point in time from the audience or anyone, I'm keeping an eye on both. Please don't hesitate to put any questions out there. If you have any questions to a specific panelist, please let me know through the chat box. I will definitely try to get back to that questions. I think I'm really excited at this point with so many great discussions and panelists. So another request to everyone, do you mind mute your microphone, because sometimes it can be disruptive to the panelist. So I will come back to Dr. Kobir Ahmed Khan now. So my question to him, Dr. Jawad mentioned that it really takes a village to take care of this healthcare system. You cannot do it all. And you really need to develop a structured program to train the next generation physician. And what are the some of the qualities that incorporate into it? So I would like to know from Dr. Kobir Ahmed Khan that what is the training program looks like in Bangladesh, and what is the plan going forward? And if you want to make any comment regarding allied health professionals like Dr. Zakaria mentioned, and how reflective that is on the teamwork.
Thank you very much. Actually, I should start with the training pattern existing in our country, in Bangladesh. We don't have any undergrad training program or curriculum on family medicine in our country, but we have the postgrad training, and that is formatted training. And it is, the Bangladesh College of Physicians and Surgeons, that is BCPS, which is the highest authority to award the postgrad degrees and FCPS degrees, postgrad degrees for the family medicine. And it starts since 1996. But unfortunately, as in our country, we couldn't establish a place or any rules and regulations for their primary care physicians. The young fresh graduates are not that much interested to adopt all those training programs, because the MCPS requires 1 year training and the FCPS requires 4 years, now 5 years training to complete the training and then the examinations. So this long training program, which is very much organized, and the residency training, this is not attracted to the young fresh graduates. So the only 75 members, that is MCPS family medicine, is there from 96, and the only one fellow FCPS graduated from the BCPS from since 2000. So this is the figure, the recognized figure, that is the BMDC recognized degrees, postgrad degrees. But there are some other degrees also privately that are running, the academic family physicians, and another one is the Bangladesh College of General Practitioners. They are running their fellowship and diploma degrees, but those degrees are not recognized by the BMDC. That is, government recognition is not there. But as you know, the only few countries like India, Pakistan, and Bangladesh, we are after MBBS we can go for GP. For that reason, the the graduates are becoming the ad hoc GP. That is, they are going for the GP and they are trying to enter into any specialty or subspecialty. They don't want to take this GP as a specialty, or they don't want to this GP for their future career. For that reason, we are telling them that the ad hoc GP, they are doing GP, but they are not the specialist GP. So the training pattern is not that much strong or that much attractive to the young generations, young doctors. So doctors are not coming to this subject to adopt the specialty. But nowadays, the BCPS is trying to organize this training pattern students friendly, and to make it standard so that it can be accepted by the other countries also. And they are making the new curriculum and MCPS and FCPS curriculum, and other private organizations also, they are trying to some universities are there trying to start their MD courses or some diploma courses here, so that they can create some manpower on the primary care physicians to work as the primary care physicians, or they can lead the future primary care physicians, so that the primary care strengthening can be done in our country. So this is the actually the condition and status as the socially the image and the what I can tell, the status of family physicians or family doctors is not that much high in our society. So we are not, cannot give these positions to the young fresh graduates to come into this subject. Actually,
Thank
this
you,
is
Dr.
the
Kabir
actually
Ahmed Khan.
state of here.
So I think what I'm hearing again and again from different panelists from different countries, that is the branding issues, how we can create the value and go to our trainees, as well as create an awareness among the population of the country that how valuable the family medicine is, right? So for that, I think we really need to, I will go to Dr. Abdul Jalil Khan. I think our next move is to create that well-trained physician and who can provide high quality care and who can be very confident and be really proud of a family care physician. So how we can educate or create that branding for the family physician, and if you also make a comment, how we can establish a referral system among the community and the specialist and the primary care physician. Dr. Abdul Jalil Khan.
Okay, thank you very much, Chandan. The first part of the question, I would say, how to make it attractive, how to make it more credential. You need to incentivize. With due respect, I would, I know Dr. Zikria mentioned it's not only the incentive, but my definition of incentive is a bit different. I give you the Dr. Khan's 5R formula for incentivizing it, and that's respect and recognition. So during the training, you need to give them respect. You need to treat them as any other specialist. You need to create more training slots in family medicine. You need to create that both in tertiary care and primary care. You need to ask the other specialty. Again, like in Dr. Zikria, I was trained in UK. Other specialties trainees used to come, get trained with me in general practice, and some of them even decide to change their specialty to family practice. So the same can go. We have a lot of trainees in Pakistan who are doing their training in various super specialties, but they don't get a chance, to go spend 6-month rotation in general medicine or general practice, because there are not enough supervisors or trainers. You need to identify the boundaries clearly. What is internal medicine? What is family medicine? So people know what they're talking about. Recognition, when you talk about the recognition, you need to develop a directorate, you need to develop a family medicine specialist cadre, you need to create jobs for them. You need to develop it at both undergraduate and postgraduate level. You need to create training slots, and that's paid training slots, so people choose this as a specialty. And then how you're going to retain them. So if you give them respect and recognition, you'll be able to retain them by giving them job opportunities, choice of work area. I know somebody mentioned that people may not want to go to the rural areas, but if you give them choice, like any other specialties, people get incentivized to go to rural areas. The same can go for primary care. Again, primary care is not only for rural areas. That's another misconception in our country. People think that only rural areas will have primary care, while the cities, because you can approach specialists directly into teaching hospitals. So no, we need to have opportunities in major cities as well. We need to retain them in the same place, because in public, that's another issue in Pakistan. You get established in one area and you get transferred the next year, you don't even know. So obviously you give them chance so they can educate the children, they can have this. If you do them, then obviously you will be able to give them the reward of training, reward of jobs, reward of supporting them in regular CMEs, and then they will be able to give you the result. And the results is going to be what? Improvement in service, necessary referrals, secondary and tertiary care, because of the gatekeeping role of GPs. And the most important thing, it will increase the patient trust. At the moment, patients feel that GP is not as much qualified. While if you go to UK, people would think if they go to A&E or if they go to the OPD without being referred, they may be seen by a consultant family physician who is certified and has completed his training. So people have more trust. So the same we need to bring in Pakistan. You need to create, in South Asia, you need to create referral system. And the referral system could be, again, incentivizing it for the patient. If I go to my primary care physician or my family physician, I would get a direct referral to the specialist if needed. And then I will be to the hospital. You don't know, you may be seen by the junior most doctor, you may be seen by the advanced nurse practitioner, or you may need to see a senior doctor, professor, for your problem, because that could be a complex. We did talk about with the government to create like a referral desk, like people who get referral, they get prioritized because they got referral. And then again, arranging, providing transport, creating referral system through electronic referral, or even like telemedicine, because patients are worried, like, tertiary hospital may not, what we learned from the current pandemic. So people can sit with the consultant family physician and they can be seen by the specialist through telemedicine, and they can advise. And so people can also see the outcome as well in terms of both improvement in care and in terms of accessibility. So that's how you need to incentivize it for both patient, for the GPs, for the doctors, and it will definitely only be possible once the patient have developed that trust and they know that this is my first contact. My care is coordinated with the specialist, i.e. the specialist need to then write back to the primary care physician, who can then do the follow-up for the patient. And that's how we're going to develop trust, and that's how we're only going to be developing a referral system. And that's the lesson learned from not just the developed countries, also the developing countries. If you look at a lot of countries, Cuba have very good system in place. Iran is currently working on developing family practice support system. Also in Gulf, a lot of raising hands. So that's from my side. Thank you.
Thank you, Dr. Jalil Khan. I think you brought up another important point to that conversation, that family physicians are consultants as well. The way I look at them, they're the consultants of managing chronic diseases. Like if you have high blood pressure, if you have diabetes, I think, yes, you can go to different subspecialties, but all the chronic diseases can be managed by the consultant family physician. So more and more into the conference, I can see that, yes, I think the trainees as well as the general population are not aware about so many services that the family medicine can provide. And it's not only consultant for the chronic diseases, but also they can see patients of all ages at one point and build a trust, as you said, with the family, build a rapport with the family. So my next question would be Dr. Pratush Kumar. I think I would ask him along the same theme, that how a primary care physician or a family physician can be a consultant, can be an advocate for a family or to a patient to manage chronic diseases, to avoid let's say for blood pressure, diabetes, cholesterol, to avoid that stroke or heart attack.
Right. That's very important question, more for a South Asian perspective, because by the time we are seeing that particularly India has become the diabetic capital of the world, because the number of chronic diseases which we are seeing is enormous. And to manage any chronic diseases, we need to do follow-up. And continuity of care is one of the most vital thing in the management of any chronic diseases. And the basis of family medicine or primary care is based on continuity of care, comprehensive care. So the family doctors are the most ideal place where we could manage blood pressure, diabetes, or any chronic diseases per se. That also not the treatment part. We can also prevent diabetes and blood pressure to develop in any patient if we do proper screening, because we don't only treat a person, but we also take care of complete family. So we treat persons from young age to adult to geriatric population. So even from young age, when the risk factors have started developing, when the patients are showing, when the young people are showing signs, symptoms, obesity, or there are different signs where the risk is high to develop diabetes, blood pressure, or there's family history, we can provide them some promotive healthcare or preventive healthcare so that we can prevent such diseases. Thank you.
Thank you, Dr. Kumar. I think you mentioned a great point, like quality of care, right? How we can provide to prevent that fatal diseases. I think one thing that we always talk about, that in Southeast Asia, we have a concept that we need to go to a doctor when we are sick, but we need to go to a doctor to stay healthy as well. If we can manage the chronic conditions, like as you said, India and I think overall Southeast Asia is the capital of diabetes because of our food habit, lack of exercise, and we are such a high risk of developing heart attack, stroke, and everything. But people go to doctor when they have a stroke, they have a heart attack, and they have those complications, kidney problems, but not go to the doctor to stay healthy. So we really need to provide quality care and tell people that we really need to see family doctors to stay healthy. Now, the quality of care, I think that's such an important aspect of it. I will go to Dr. Gobind Ratnam to talk about, like, yes, we always talk about the quality of care, but how we can measure the quality and ensure it. And is there any mechanism in the training program or in your practice that we can you can discuss, or what are the challenges, future challenges you can see in that regard?
Yeah, yes, whichever the things we are going to do it, so we always measure the quality, what we are doing for them. So this can be assessed or measured under the three main cardinal one, like structure, process, and outcome as a traditional way. Like when we see the structure, so as you already discussed about this, we don't have any good health system or primary care, or is there any recognition of family medicine. So we should have the system first. So before going that, and as well we need to have the facilities for the all the things into the primary care system. So we should ensure that how we are going to put in the structure onto the care where we are going to provide. As well, we can go with the records, because normally everyone talk about even records, how we giving the care. Maybe we are not maintaining the good type of records, maybe even the paper-based or in computer-based. So we have to go with that. So how we be assessing in even the retrospective way, as well the positions, staff positions. So even we are always in the under cadre, maybe even still we are on the training process to get the staff, even almost same in the Southern Asia. So still, I think we are, most of the countries, we are on the process to fill the cadres. This what we can put in the structure. Likewise, in the process-wise, so in all the curriculum, even undergraduate, even postgraduate curriculum of family medicine, we always putting the lot of stuff to get a competent clinician, because they are the first contact people, maybe from the any age of that, even maybe they have to manage in the early emergency pre-hospital care as well. So the process-wise, we have to train them in a competent way, and always we have to ensure the quality and safety of the patient. It can be done various assessment and audit as well. And outcome also, like we have to put the targets. So what we are going to do, actually what we are going to achieve from this, even quality wise, even with the how we are giving the quality, even the clinical wise as well, we have to get the feedback from the patient perspective as a perceive what they are receiving. So these are some measurement we can say. For the future challenges, I think Jalil Khan has mentioned about that, about the future challenges. Even we have to go up with telemedicine. Even we have a bit of telemedicine provider current in the era of the pandemic. So we more towards the telemedicine. Maybe we have to more adapt with some type of telemedicine in, even though not only the delivering the services, maybe with the addition of investigation and other part as well. And again, I'm mentioning about the patient medical records, maybe personal medical records. It should be there, because then only we can do the chart care and making the referrals. So even though we have we don't have the much of proper referral system, even though we won't get the back referral. So if you do the proper care from the primary care to the secondary tertiary, we should have the good recording system, most probably in the electronic record system. And finally, again, about this, we have the challenging about the health system recognition of the family physicians. So we are on the process, even in Sri Lanka also we are on the process. I think 2030 we are able to, we will achieve half of the amount, like even we may need it at the moment we plan for 130 family physicians in 2030, but we will achieve more than that. But in the primary care strengthening, we plan to put even one doctor for 5,000 population. That's not for the family physicians, maybe some competent physician there. So if they're able to provide good even diploma, even family medicine diploma holders, it would be great. I think we are going toward the way, and we will achieve as even the country as a region with the collaborative and all. Thank you.
Thank you. Thank you. Thank you, Dr. Ratnam. I think you brought up some good points that I think we need to discuss a little bit more about those that you mentioned, that electronic medical records, telemedicine. I will come to those topics. I know we have some panelists here who are very passionate about those topics. I want to touch on another topics that I will go to Dr. Wandi Nerbu next, that we always talk about that primary care physician, family physician can see the patient across all ages and genders, and they can build a trust and relationship with the family. So along the line, can you tell us briefly that how that relationship is gonna help you to do a lifestyle modification to prevent some of the chronic diseases or control some of the chronic diseases that we always talk about, like diabetes, high blood pressure, obesity, and so on. Dr. Norbu.
Okay, thank you. Thank you very much. I think general practitioner of family medicine have a greater role in connecting community to prevent lifestyle-related diseases or combating its non-communicable diseases. Because in our country, if I cite an example, in our country, our general practitioner of family medicine, they are working in the tertiary care hospital. So since I mentioned that we are at a very infant stage, we haven't reached at the primary health care in providing all the advocacies to prevent non-communicable disease or chronic diseases. But as I heard from all of the panelists, the primary now general practitioner or a family physician, they play a very crucial role or pivotal role in preventing all this non-communicable disease or lifestyle-related disease, because patients will have a trust on our doctor who are very close to them, and we will be the better advocate. I would say like a better advocate, a better educator to convince the community regarding the chronic illnesses, how to control, how to prevent the illnesses. So to talk about the system, health system in Bhutan. So we have a 3-tier system, as I mentioned: primary healthcare, a secondary, and a tertiary. But our GP program, so it's infant stage, so we didn't reach to the primary healthcare. But in the tertiary also, in a general OPD in a clinic, I have just seen like 70 patients today. So I have a role in seeing chronic patients with hypertension, diabetes, COPD, and I had developed some trust, and the patient has developed trust on me. So I have a better position to explain them on the illness. So I think like a general practitioner or family physician have a greater role in connecting the community and coming across all the ages of life. Thank you, sir.
Thank you. Thank you. I think the primary care family physician has a bigger role to play, as you mentioned, to build the trust and to manage the chronic conditions. And somewhere along the line, I will go to Dr. Amit Agrahari next. And my question to him would be that we are talking about building a relationship with patients. So now we need to focus on the building relationship with the other subspecialties as well to prove our values. Like when we talk about the referral system, not only us referring patient to them, but they also has to refer the patient to you. So we need to create an open channel of communication with the specialist so that we can work together. So how you envision that you can create an open channel of communication with the specialist that will help take care of the patient in the long run. At the same time, like let's say acute care hospitalizations and the primary care, how you can manage that communicate better to help the patient. Dr. Agrahari.
First, we need to have a proper channel of referral from primary center to secondary and tertiary level center, and we should have we should prepare some referral slip and send the patient with the slip to the specialist. We should contact the specialist and ask if they can attend the patient on when they can attend the patient. We can contact them and ask them to look after the patients, and we can but as the referral system has not been developed yet in our part of country, we have some personal relations with some specialists while we are doing the residency program. So when I usually refer my patients, I usually use my personal contact to the specialist before referring them. I call them and say that inform them about the patient, and after the patient reaches to the specialist, I usually contact myself to those specialists and ask about the case. But it is the wrong way. I know it is the wrong way. It should be that the specialist should inform me about what was the case, how he managed. He should inform. It is the fact that they need to call us and inform the patient to us. But as the referral system is not well developed here, that's why we are having problem. And usually they do not ask, when we refer some cases to the specialist, they do not ask them to revisit the primary care providers. They usually ask the patients to follow up to themselves at their hospitals, and that way there is a loss of some trust from the patient, and they usually want to seek help from the specialist directly, rather than coming to the primary care providers or family physicians. That there has been one, this is the one important lacking in our system, health system. And
thank you, Dr. Agrahari. I think you have been trying to say nicely that how important this referral would work, and we need to open up a communication. I think we are almost 2 hours, but there are so many important topics that we touched, and there are so many that we couldn't touch. But I really want to touch the 1 or 2 other points before we come to a conclusion. One would be, I think it will be really, we really need to touch the digital innovation, like how that our technology can help us to promote or to provide better health care. I will go to Dr. Zakaria to say a few words regarding electronic medical record and how that can help patients and give them the ownership. Dr. Zakaria.
Thank you, Dr. Mitra. I'll be very brief because I'll have to go to another meeting. Just going to say that general practice in the UK is more than 100 years old. We've been using the listed patient service from 1911. And from 1948, the formation of this National Health Service, whole thing is nationalized. And since then, we have got a list-based personalized medical services. And following to that, in 1980s, the electronic patient record started here in the UK. So it's a very mature system. And 1990s, the whole load of different providers providing EMR. So it's now kind of compulsory to have an electronic record system in the UK. So this piece that we've been working with in the last few years is to how to connect different systems. So one GP system using EMIS, another one using System One or Vision Practice, or it's different EMR system they use, how to really connect them with each other so that a patient move from one practice to another practice can read their notes. They can electronically transfer the medical records. So that's something that we've been working. I'm a clinical lead for the GP Connect project in Southwest London, so I have special interest into that. We're also have been able to connect the hospitals. So hospitals also use some electronic system, as you know. So how this patient, when they move from one hospital to another hospital, how they can actually read and write back into their notes. This agenda is actually known as interoperability, or in short called Interop. Funny enough, we've been using an American company called HIE Sarna, Health Information Exchange Sarna, who's been actually helping us to connect our hospitals in London. So it's called One London Project. You can Google it and you can have a look at it. It's called Interoperability in London. So that's the very interesting part of the digital innovation, which is helping us. So the patient, they don't need to really duplicate their test or tell their story again and again when they travel from one clinician to another clinician. Or they might be attending ED, next morning coming to you as a GP, you don't really need to repeat those tests, or they might forget their discharge summary, but you can look it up. That's a very useful innovation. The other piece that we've been working on is the electronic way of accessing services. So my previous agenda was under access. So how people can actually access their appointments or their services, shall we say. We don't say it as a GP appointment anymore. The practices are providing appointments. So within the practice, you have a different types of professionals. So you can have a directly bookable appointments with the physiotherapist or a talking therapist, like a psychologist or somebody else of, there are lots of different types of people working within the primary care. So how can they actually access those services without coming to have a face-to-face conversation with the general practitioner? So there's something as an access agenda. So the out of hours care is another one that we've been working on, which is basically when people call NHS 111 or 999, like emergency services out of hours. So how they can actually see or view the patient record and make quick decisions. So these are some of these. It's like a snapshot of what is happening in digital world. I think that's the way to go. Now things are happening very rapidly, and that's a growth sector. And we are actually incorporating some of the artificial intelligence within the EMR. So basically, if you write down a patient blood pressure is such like 180 over 100, or let's say 70 over 40, and pulse is 120. So that patient, your computer will tell you that patient might have sepsis and prompt you to do things. So it's basically something that it's kind of a digital assistance which is coming into play. So these are some of the innovations happening, and I think the South Asian countries are they will be very good at replicating those. I know during the pandemic they've been very successfully doing telemedicine, and there is a big drive to digitize things. Even in Bangladesh, the digital Bangladesh is an agenda for the government. I must say that I'm proud to say that they have done a lot of work to digitize lots of other sectors like banking, Uber, and lots of other areas, but health sector is behind. And we need to do a lot of work to be able to do that. Because of the time limitations, I'll stop here. If there's any question on this particular matter, I'm happy to help with digital sector. And if there is any need to develop general practice back home in Bangladesh, I'm more than happy to help through the Royal College of General Practitioners, or here within the, I'm also work, locally, we have got a network of practices where people will be more than happy to exchange ideas and training. Thank you.
Thank you, Dr. Zakaria, for your precious time. And I think show us the path forward. I know that digital innovation is coming, regardless we like it or not, but surprisingly enough, in our hospital, we use the Cerner products as well. So I can correlate some of those things that you mentioned, that how you can recognize sepsis and, like how to manage diabetes or blood sugars in the hospital. They would give us some recommendations through the artificial intelligence. So I think that is the next generations. But I will go to Dr. Hina Jawad for one more questions. Like one, we are talking about the electronic medical record, but another thing that the access of healthcare, how we can revolutionize the access of healthcare through the telemedicine. Dr. Hina Jawad.
Thank you. If Dr. Zakaria can still hear me, and if you can share that website address in the chat box, that will help. Yeah. I was actually part of the telemedicine services last year during the first wave of COVID, and we supervised a telemedicine center at the university. We were inundated with lots of requests from volunteer doctors, junior doctors, finally medical students. And when we provided those services for a period of 6 months, we realized a lot of things were happening. We were gaining access to the marginalized population, the low socioeconomic deprived population, which were at the mercy of the quacks or the unqualified doctors. So I think that was definitely an opportunity, because equity is something that is part of general practice as well, and diversity and equity is another thing. So yeah, I think that was one thing. And the other thing that happened was improvement in the consultation skills of the junior doctors. They were able, because the patients were not in front of them, they were able to kind of explore more data so patient safety and competency was another thing that we developed. We are carrying out a research on it, so the results are coming out as we speak. So I think these were the main two findings. patient confidentiality, electronic medical records was something we couldn't achieve at that point in time. Most of the records were paper-based, but we are trying to now shift them to the medical records now. It's a huge task for us. We need a lot of data operators and people like that to work on it. But I think we are quite lagging behind in that area, in real honesty, and that is something we need to kind of speed up and look into more. Thank you.
Thank you. So I have been learning a lot during this conference today, and we are talking about so many different things. I think we can go for hours, but I know that everyone has their time limitations, and we have to wrap up at some point. I want to just ask one more questions before we conclude the session. That we talk about the opportunities of the family medicine, how to brand the family medicine, how to educate the next generations, how to create awareness, how to create communication between the consultants, and so on. And what are I think one important thing we talk about, I think everybody talk about the challenges to establish all those things. One of the topic that we talk about, private then government partnership as well. So I will ask my last question to Dr. Kabir Ahmed Khan. Is there any model institution in Bangladesh that can show that how the family practice should work? Or is there any plan for private government partnership in Bangladesh?
Yes, thank you very much for giving me a last chance. That is actually in our country, and we can take the budding stage. The family medicine, family doctors concept is in the budding stage in the general population as well as the other professionals also. So we are lucky here. In private sector, there are some initiative they created here to familiarize this concept to the population. And one of them, in which I am working as a consultant family medicine, the Prava Health. This is working since 2017, almost 4 years. And by this time, they established a standard model of primary care and in the urban setting, and this is working very nicely. And this model is for the young graduates and as well as the general population. They are doing wonderful job to provide the family medicine care and the family doctors care to the population, as well as you already mentioned that we are not only treating the patients, we are also giving some plans for the populations, general populations, so that they can they have the risk management, risk assessment, and through risk assessment they can prevent they can screen their chronic diseases, and they can prevent all those things. And we have the health professionals here, all sorts of health professionals here, and it's including the health educator and the family medicine specialist and the other primary care physicians. So this is actually we are using the electronic medical records, and the first apps we started here for the patients and as well as the doctors. So the Prava started here, the electronic health records also, and this is also they are using one apps through which the patient can assess the situations, and they can using the artificial intelligence. Through artificial intelligence, they can assess their conditions, and they can consult or contact with the doctors and with our healthcare professionals. So this is actually in our country, though in the government level we cannot establish the family medicine here, but in the private level like Prava Health, there are some other, suppose the BRAC health initiative, they are also started this type of healthcare facilities here, and the private healthcare facilities are doing very good through the primary healthcare strengthening and family doctors concept they're establishing here. Thank you.
Thank you. So as we are almost at the end of our session today, if before we go to our conclusion, is there any issues that anybody want to talk about or we missed, or just want to give one last opportunity? Yes, Dr. Jalil Khan.
So I couldn't raise the hand in the other way. Yeah, just last bit, as I said, we need to create the demand. So whatever I heard from the other countries, I think is a similar experience in our countries. But if you listen to Dr. Zikria, what he was saying, like, GPs and a lot of demand. So you need to create that demand. Primary care comprehensive model can only be possible through the family practice approach. And that's the vision of WHO. And that's the only way forward to achieve the UN Universal Health Coverage Package by 2030. So if we manage to ask our governments and our for family practice approach anyway, and the only thing we ask for is which can promote everything is if they create a demand. And I've just one of the WOMCA South Asia president just shared information about a province in India, presumably Uttar Pradesh, where they've managed to create posts for MD family medicine. So I think that's the only way forward. If we manage to develop what we call in our country as family medicine cadre, or jobs specifically for family medicine, and get them as district specialists or get them recognized. So if we create a jobs for both faculty level and primary care facility level, then automatically that will create the demand, and undergraduate students and the postgraduate trainees will choose this as the career. So I think this is the only way forward, or at least that's what I've learned from my limited experience since I moved back from UK. So I hope if we have a similar sort of approach, I think that will create the demand, that will bring opportunities. Thank you.
Thank you, Dr. Jalil Khan. I think that's a great point, that we really need to create the value and the demand. Now, I would like to request our chairperson, Dr. Tasbirul Islam, to make concluding remarks. Dr. Islam.
And thank you, Dr. Chandan Mitra, for your wonderful moderation. I want to thank all the panelists for wonderful comments and advice. And we discussed a lot of things, and I know in one session we cannot finish the discussion. We cannot come to the conclusion what to do, what not to do, how to solve, and what the challenges we have. Pretty sure we need a follow-up session as well, and we keep doing this one. I promise. About this family medicine concept to establish in South Asia. We discussed about the leadership, we discussed about the vision, we discussed about the, that we need a budget for that. I don't know, in South Asia overall, the budget for the healthcare is very poor. If you look at the GDP, in Bangladesh, I can say only 1.3 or 1.5% of the GDP goes to health sector, and that is only 5% of the total budget. It should be at least 15% of the total budget, or 5% of GDP. I think more or less similar in other countries as well, except Maldives, I think it's way ahead, and then Sri Lanka after that. And that is another issue, is we need to increase our doctors patient ratio and nurse patient ratio as well. It's very poor. I never heard, I don't know the other country, in Bangladesh actually, number of doctors is higher per 10,000 than the nurses, and that is unheard actually. Nurse should be the higher than the physicians. we talked of the leadership vision, then we need a budget and we need the training. We talked of the training. We don't have the structured training for the family medicine. We need to disseminate the concept of family medicine, and people should know what is family medicine. Sometimes, and I heard one person is telling me, "Oh, family medicine doctor, you know, I don't have a family, I don't have a kids, so how can I see the family medicine physicians?" You know, that's the concept they have. You know, if you don't have the kids, they don't have the family, they don't need to see the family medicine. So that need to be, you know, addressed and corrected, and mind change there need to be mind change. You know, there should be acceptability. And it cannot come just by one person. It has to be collaboration between government, public, and private. Government has to take the initiative. As all said, incentive is very important. And I can tell you one story here. When I started my residency here in US, after I moved from UK, I was in the United Kingdom before I moved to US. Nephrology was a very difficult fellowships to get into at that time. And because there is good reimbursement, and so because they get a lot of payment from the hemodialysis, eventually the reimbursement for the hemodialysis is taken away. So the salary went down significantly. Now nobody go to the nephrology fellowships. Really, the slots are empty every year. It's easy. You can walk in and get the fellowships in nephrology. But during my time when I was a resident, it's impossible to get. It's so difficult. So that's the way it is. You know, incentive is so important to track. Not only does the reimbursement model, when you go to the job, you have to attract the trainee. So you have to give some incentive when you're in training. You have to give incentive, like, you know, scholarship, like, you know, better, you know, lifestyle. You need to attract people, and the referral model, that the effective referral model, they know the patient has to come to me before they can see a pulmonologist or a cardiologist. So I think we discussed a lot today. It is a very effective discussions. I want to thank you all the panelists, all the participants. On behalf of Planetary Health Academia, I inshallah will stay in touch. We'll do more session on this. And I also request you, please help us to grow the Planetary Health Academia. And I also invite you to become a faculty members of our group. Over to Chandan Mitra, please. Then lastly, one thing I want to say, I want to thank you, Dr. Kobir Ahmed Khan. The reason that he actually brought up this you know, topics and approach to me that we should do some session on family medicine, the situation in the South Asia. So I want to thank you, Kobir Ahmed Khan, and also thank you, Chandan Mitra. In such a short notice, he did the moderation despite his busy schedule, and surely thanks to all the panelists. Thank you, Chandan Mitra.
No, thank you, Dr. Islam. I think I want to thank you, all the panelists, all the participants, and as Dr. Islam mentioned, Dr. Kobir Ahmed Khan, I can see the passion and the enthusiasm in him. And I also want to thank the Planetary Health Academia to create the platform and give us the opportunity to have such a wonderful, informative, and engaging discussion. It's a privilege to be a part of this discussion. And with that, I want to conclude today's conference. Thank you all.